Alright, so next up is multiple myeloma. So multiple myeloma is one that's going to infiltrate the bone marrow and actually form lesions or masses in the skeletal system. So it works by concentrating on the plasma cells. It attacks the mature B cells that make antibodies, but remember they also travel throughout the body. So whenever those B cells mutate through the plasma, they're spread to different bones in the skeletal system and start causing these masses within it. Elderly folks, African Americans, and men are at greater risk. Environmental exposures such as smoking and ionizing radiation can also cause problems. It's often asymptomatic. What happens is people might have a problem with like a bone breaking, or they may just have an x-ray for something else, and it turns out they find it on their scans as an incidental finding. Okay? It affects about 3% of all adults who are over the age of 50. To diagnose it, an individual has to have all three of these things wrong. So greater than 10% of their plasma cells in the bone marrow have to be malformed. Alright, so on biopsy we see these cells called plasmacytoma. They also had to have a staining done to those cells. So if you think back to like microbiology, if you took that kind of class, we can stain cells to see different membranes and different parts of them. So they would do a special staining for the monoclonal immunoglobulin, which shows up like a light chain, and we would know that they have a certain M protein in them, and we know that those cells are related to multiple myeloma. They also had to have evidence of end organ damage, which you can remember by thinking of crab. So they have high calcium levels, or hypercalcemia. And this is because as the lesions infect the bone, it's going to break the bone down. And your bone is mostly made of calcium and phosphorus. So all those get released into your blood supply whenever the bone gets broken down from the tumor formation, making the patient have hypercalcemia. They'll have renal insufficiency, because remember your kidneys are the ones that mostly process all that electrolytes and different toxins in the body, so all that extra calcium and phosphorus is going to junk up the kidneys and make them not work as efficiently. They'll have low red blood cell counts, which will show up as anemia, and then they'll have the bone masses or lesions. So these are images of people who have scans who have multiple myeloma. If we look on the right here, this is an x-ray, right? So it's an x-ray of their skull, and these white kind of grayish dots here are what shows up as lesions. You can see it's a little bit harder to actually see in an x-ray because it's within the bone. They just show up as kind of these darker spots. You have to really be careful when you're watching for them. If we do a PET scan, so remember that's the one that's looking for increased metabolic activity or increased glucose use by cancer cells, we can see them a little better. So for instance, this is somebody's rib cage. So there's a tumor in their rib cage. This is like a bottom segment of their pelvis. So there's one there. This is an upper portion of the pelvis. There's one there, right? And overall, their flat scan, you can see it's in their skull, their ribs, their pelvic area, the little spots around on their bones too. Alright, so next up we're going to talk about lymphomas, but let's think about the differences between leukemia and lymphoma. So leukemia is going to be a problem where there's cancer in the bone marrow. It's going to impact the cells that form your blood, right? Either red blood cells, white blood cells, or platelets. The leukemia has the cancer in the bone marrow, so those things can't develop and they divide uncontrollably. Lymphoma, on the other hand, can also impact our B or T cell or lymphocytes, the white blood cells. Most of them, it's going to be the B cells infected, but what it is going to target more instead of the bone marrow is the lymphatic system. So these tend to grow tumors in the lymph nodes. Multiple myeloma Lymphoma is whenever we have cancer of the lymphocytes, particularly usually the B or T cells, and it's going to cause enlarged lymph nodes. So most people, the first sign that they recognize is that they have these abnormal nodules on their neck or on other areas of their lymph nodes. There's two types. There's Hodgkin's and non-Hodgkin's lymphoma. So Hodgkin's lymphoma has the highest incidence in North America and Western Europe. It has the lowest rates in Black and Asian populations. People who've ever had mono with the Epstein-Barr virus are at increased risk. If they have a genetic family history, they're at risk. And what we see is if we stain the cells during testing for Hodgkin's lymphoma, they're going to have the specific malformation of the Reed-Steinberg cell. All right, it's a mutation of cancer-causing B cells. So these start off as B cells that have mutated, and they form this kind of, you can almost see 3 old B cells in there that have gotten clumped and mutated together in this abnormal shaped cell wall. All right, that is the Reed-Steinberg cell. All right. It can cause lymphadenopathy. All right, it especially gets painful in your lymph nodes after they drink alcohol. They can have chest symptoms. So you have lymph nodes around your heart, like in the center of your chest cavity. That's the mediastinal area. If they have swollen lymph nodes or infected lymph nodes there, lymphadenopathy, then they're going to have chest symptoms like difficulty breathing and chest pain, things like that. They can also end up with what we call B symptoms. So these are symptoms related to the B cells not working. They're secondary to the cancer. So people will experience things like night sweats, fevers, and they'll often lose about 10% or more of their weight in less than 6 months. We can treat this with chemo and radiation, and about 75% of people have successful survival rates after treatment. The other type of lymphoma is non-Hodgkin's type lymphoma. This is a catch-all for any type of lymphoma that doesn't have the Reed-Steinberg cells. So if it has the Reed-Steinberg cells, then we know they have Hodgkin's lymphoma. If they do not, but they still have cancerous lymph nodes, then they have non-Hodgkin's type lymphoma. About 85% of them start with the B cell, about 15% of them are mutations to the T cell. It's increasing in incidence because we're seeing people who have immunosuppressive diseases living longer, and the longer they live, the increase their risk is of getting non-Hodgkin's lymphoma. So patients who've had HIV or AIDS, people who have immunosuppressive disorders, especially medications, so people who've gotten transplants, and people who survive long time after transplants are at increased risk for this. It gets divided into aggressive and indolent subtypes. So aggressive is just what you would think. It's very rapidly progressing. It affects a diffuse and very large population of the B cells. It's the most common is with the B cell type, not T cell. And if we don't treat it aggressively, then it can cause death very quickly. Indolent means that it's slowly progressing. It's usually impacting the follicular cells of the lymphatic tissue. So risk for non-Hodgkin's, your family history, people who've been exposed to carcinogenic chemicals or radiation, things that we know can cause mutation. Certain bacteria and infections also increase somebody's risk. Anyone who's ever had stomach ulcers or gastritis related to a bacteria called Helicobacter pylori, usually called H. pylori bacteria, they're going to be at increased risk. People who've had hepatitis C, especially if they've had spleen enlargement, they're going to be at risk for splenic lymphoma. People who've had Epstein-Barr virus, again, that's one that's commonly associated with mono. All right, they can also go through a lymphoproliferative disease after it. Right? And then there's a rare virus called human T-cell leukemia virus. They would be at increased risk. And that one is usually the types that are attached or most closely linked to T-cell lymphomas. People who are on immunosuppression, all right, so HIV, AIDS, anti-rejection medication users, they're going to be at increased risk. Clients, whenever they have these conditions, what things we're going to see, If it's aggressive, they're going to have symptoms very quickly, and if it's indolent, they may take a long time to show up. If it's aggressive, they're going to have a rapid onset and they need to be treated urgently with chemo and radiation. Indolent, they're going to have a slow progression. They often won't have any symptoms at first. They'll be asymptomatic. We usually wait until they get symptoms in order to treat it. They're going to all have lymphadenopathy, so that's the infected enlarged lymph nodes. Most everybody also gets the B symptoms. There's ones related to the cancer impacting the immune system, fever, weight loss, and night sweats. They can also have impairment to their central nervous system. They can have things like seizures, headaches, changes in mental status, some focal or contained neurological defects, so maybe they're only having a seizure in part of their brain and not all of it, in other words. And then it can also impact the bone marrow and cause anemia and thrombocytopenia as well. Alright, so that is the last of our blood disorders and cancer discussion. If you have any questions, please call or email me anytime, and I'll see you soon in class.